Good evening, everyone. Thanks to everyone for driving here and weathering the risks of weather yet again in July in Vermont. But we really appreciate the strong turnout tonight. It's really important that we hear feedback, and we thank everyone for taking the time. My name is Owen Foster, and I'm the chair of the Green Mountain Care Board. And we're here today to discuss some findings that Dr. Bruce Hammery, sitting next to me, and the Oliver Wyman team have been working on for the past 10, 11 months or so. Before we get started, I want to provide just a little bit of housekeeping. There's some food and refreshments up at the top and the back. I'm told to tell you where the bathrooms are, but I have no idea where that is.
Right back there.
Also back there. Exits, just be aware of where they are in the back. And I think there's one here and one over there.
Yeah.
For anyone who needs closed captioning, let us know and raise your hand, and one of our team members can assist you with that. There is closed captioning available. And there's also media here today to provide some coverage of the meeting. There will be floating mics that we'll bring around for people who have questions or comments who want to provide some feedback. We're going to provide two different moments where people can raise their hand and provide feedback. We'll take a break, maybe about halfway through Dr. Hammery's presentation, and then again at the end. The program is scheduled to run for an hour and a half, and we can try and stay a little bit late if people have questions or answers after the session is over. We'll try and keep questions and answers to a minute and a half or so, just so that we make sure that we respect everyone's time and we get through all the questions and everyone has a chance to speak. I also wanted to acknowledge that we have some legislators here tonight that are participating and providing information and work on these kinds of issues every day during the legislative session and when they're not in the legislative session. We also have some hospital leadership here. CEO Peter Wright is here, and he'll say a few words after this evening as well. And we also have hospital board leadership attending as well. And Secretary Samuelson from the Agency of Human Services will introduce herself briefly. And lastly, certainly not least, I want to introduce Mike Fisher from the Office of the Healthcare Advocate. They provide a lot of work helping people with issues getting coverage and finding care and any odds and ends of issues you may have navigating our healthcare system here in Vermont. So with that, I wanted to provide you some opening remarks about what led to this project and why we're doing it. For years, we at the Care Board have heard that healthcare in Vermont is unaffordable. This has been said in Vermont for a decade, if not two or three. Employers and families are facing skyrocketing insurance premiums, and patients are grappling with rising insurance premiums, rising out-of-pocket costs for x-rays, office visits, procedures, and drugs. And in a nation with some of the worst healthcare costs in the world, Vermont is one of the states with the most expensive healthcare. We indeed have a healthcare affordability crisis, and the Green Mountain Care Board sees this every year when we get insurance rate requests submitted to us. Last year, they were about 14 to 18%, and this year, they're again 10 to 20%. I think in the past, we thought this would be a blip. We thought it was COVID, we thought it was inflation, we thought it would go back down. It hasn't, and we do not see signs of that abating. And that makes this moment to make decisions to ensure affordability really important. And the communities feel this. Employers see these rate increases every single year as well after the Care Board reviews them and if they're approved. At the same time, we have immense challenges with access to health care. We have a hard time getting access to primary care, we have a hard time getting access to specialists, and we have wait times that are frankly unacceptable in many places throughout the state. I myself struggled to get a primary care doctor for many years in the state, and even after I became the chair of the Care Board, I kept hearing how hard it was to get a primary care provider. I called 7 within my first month and did not get anything better than a wait list without any sort of expectation of when I could get in. It's different in different towns and different communities. I'm in Chittenden County, but it's a problem kind of throughout the state in a number of places. That's very difficult when you're paying these kinds of rates to have that kind of challenge just seeing a simple primary care provider. If not addressed, these very real access and affordability problems can mean the difference between life and death, or the difference between a life well lived versus one spent in sickness, pain, and medical debt. Vermont has a rising and unacceptable level of medical debt, and we have a very high level of what's deemed insufficient premium health care insurance coverage. It's rising, and it's because the costs are high. At the same time, we have an immense challenge with sustainability of our healthcare system. Independent providers, hospitals, all providers in Vermont are struggling with having enough financing to keep their doors open to provide the care that your community needs. We hear it from hospitals, we hear it from independents, we hear it from primary care, we hear it from mental health, we hear it across the state. So costs are going up, access is a challenge, and the ability for our providers to maintain their operations are struggling pretty significantly. Last year, 9 out of 14 hospitals in Vermont had negative operating margins. That is, their operating revenues did not cover the cost of care that they delivered. This is especially troubling given that the Green Mountain Care Board that year had granted a change in charge increase of over 10% in an effort to ensure hospital sustainability and financial solvency. But double-digit changes in charge must be paid, and they're paid by community businesses and Vermont families, and families are struggling to pay those bills. It's important to note that hospitals are not the only component to those increasing premiums. They're a significant driver, but they're not alone. A sicker population costs more to insure. Greater utilization of healthcare services costs more to insure. Drug prices increase, we pay more. Utilization of pharmaceuticals goes up, we pay more. So there's a whole number of components that cost a lot of money, many of which the state has no control over. We do not have levers at present to control how sick people get, how much care they access, or what pharmaceuticals cost, or how many people take. Vermont is not alone. Rural hospitals throughout the country are facing challenges financially. So the question now is, how do we respond? Nationally, we've seen many, many hospital closures, and a lot of hospitals will close unprofitable but essential services like maternal and pediatric care and mental health. We do not want that. That is why we are here. We do not want unanticipated, chaotic, unplanned changes to service lines. We want thoughtful and careful consideration of what needs to go where and how we're going to pay for it. Also of note that's important is our state is aging, and it's a real challenge across the entirety of the state. We're getting older. That challenges our workforce, and it challenges our ability to pay for health care. Because it's the commercial market, people aged 20 to 65 on commercial insurance, that really pay well for our providers to keep them solvent. As we age, the number of people paying a lot of money through their insurance plans goes down. That creates financial strain on the system. As we age, the number of nurses and physicians are not there. We lose them. We have housing challenges, we have demographic challenges. These are impacting the state in so many ways. Education and healthcare, very significantly. So what are we doing about it? Dr. Hammery, who's sitting here for the past 10 months, and his team have held over 100 stakeholder meetings and community listening sessions, reviewed volumes of state reports, visited every hospital in the state, and analyzed data to assess the ability of our healthcare system to meet the needs of Vermonters now and in the next 10 years. While this is a challenging time, it's also an immense time of opportunity because we can right-size our system and create a system that works for what our needs are. We can align it with what we need rather than having the historical features of our system. We can make it intentional for what we need as we age. So more mental health, more primary care, more long-term care, more home health and hospice, and memory care. Those are going to be in significant need today, and they're going to be in the future. The analysis that you will hear today is unique. No other state is taking such a comprehensive, data-driven, community-inclusive, proactive approach to assessing the current and projected state of its healthcare delivery system. No other state is looking at the demographic and expense growth trends and trying to envision a delivery system that can both meet community needs and withstand the headwinds financially that are coming its way. No other state is seeking such comprehensive and innovative solutions. So this is a time of opportunity and choice. We can sustain what we currently have, but it might take significant tax increases from our legislature, right? It might take incredible increases in our health care insurance premiums. Those are options. They're not really favorable ones in my mind, they're difficult ones. We can also have a system where we try and design it intentionally in a way that we do not lose local care and essential services that we need. The legislature has directed the Agency of Human Services, in collaboration with the Green Mountain Care Board, to lead the next stages of this transformation process. The Care Board and AHS are not here to close services or to close hospitals, but to get feedback and come up with solutions that we can work with together with local leadership, like Mr. Wright and their board and the community, to create what we need in the state. It will take time, but it's essential that we start working on it now because the runway is fairly short. With that, I'll turn it to Secretary Jenny Samuelson from the Agency of Human Services. And thank you for having us.
So again, I want to echo Chair Foster's appreciation, both for everyone coming out tonight and for the work that many of you have embarked on with Dr. Hamry over the last few months to help to inform the recommendations that you will hear tonight. I want to echo Chair Foster's sense of urgency. We are at a critical moment in the history of our healthcare system as we look forward. As we think about the healthcare system, we have increasing costs for Vermonters, as Chair Foster laid out. We've also seen significant strain on Vermonters in terms of affordability in our systems. These have been affected by significant demographic shifts and economic pressures that have impacted us from COVID, but were also historically before the COVID pandemic and continue after the COVID pandemic, things that we need to address in our larger macro environment. These present both opportunities and obstacles to us as we think about creative and collaborative solutions. So not only do I want to thank you for coming tonight, but I want to thank you for being a part of the process as we go forward. This is not something that the hospital can do alone, that the Agency of Human Services can do alone, or that the Green Mountain Care Board can do alone. It's something that we need to do collaboratively together with this community and with communities across Vermont. You will hear a lot of recommendations, and I want to reinforce the need for investments in both our healthcare and our human services system. Investments in elements like mental health, preventive care, long-term care, substance use disorder treatment. Many of those things were well on a path, and this community and this hospital have been on a path for a long time. In fact, we've invested, along with the legislature and others, more than $212 million in that type of care here and across the state. I want to recognize, though, that what Dr. Hamry's recommendations really do today is that they lay out a set of thoughtful recommendations for how we might continue to advance that, because while we've come a long way, we still have a long way to go. So I don't want to take up much of your time. Chair Foster has laid out the issues. You'll also hear from Dr. Hamry what some of the recommendations are as we move forward. But I want to empower us to take a thoughtful approach, to take a collaborative approach as we look at the direction that we're going. Your input is vital. The set of recommendations are not final. We're here to gather your input and your feedback so that we can alter them and change them. You know the landscape of Franklin County, and while I graduated from here and I've worked here and I've lived here, I don't know everything that there is to know, and so it's really vital to hear from community members in Franklin County. We need your feedback to understand the unique needs of this community. These recommendations will also help to inform our future work together through our learning health systems activities as we carry this forward. In closing, I want to emphasize that this is not just a dialogue for today, but it's the beginning of an ongoing conversation. We must continue to work together as a community to address the challenges ahead of us, and I'm confident that we can do it. And I'm confident that our healthcare system and the health of our communities and populations will be stronger for it. So thank you.
Thank you. Thank you, Secretary Samuelson.
Got it. Mr. Wright. I thought you were going first.
No, your turn.
Good evening, everybody. My name is Peter Wright, and I have the pleasure and honor of being the President and CEO of Northwestern Medical Center. If I were to pick 3 words that describe Vermonters, particularly the people who live and have grown up in Franklin and Grand Isle counties, I would say strength, resiliency, and leadership. Northwestern Medical Center has been at the leading edge of doing what's right for its community for 140 years. And every single one of the 800 people on our team are committed to making sure we continue to take care of this community for the next 140 years. A couple of facts. This is not our process, but we are an active and willing participant in the process. NMC has been at the leading edge of healthcare reform, going back over a decade when the all-payer model first came out. We will be at the leading edge of the next generation of healthcare reform. We are one of the lowest cost hospitals in the state of Vermont. We continue to focus on how we open up access and serve the people of this community. We don't have dreams about bringing down people from Canada or serving Lamoille County or Windsor County. All we want to do is focus on taking care of the people in Franklin and Grandal counties. I think it's Darwin who said, "It is not the smartest or the strongest of the species that survives, but the most adaptive to change." Which is why if you come in my office, there's a bookcase, and on that bookcase there's a little nameplate that says, "Improvise, adapt, and overcome." That is the credo that every one of our members comes to work every day. We not only take care of the community, but we're constantly thinking about how we can do it better. So right over there is Dr. Minadeo. He is our Chief Medical and Quality Officer. And one of his principal responsibilities is to help lead our journey about becoming a high reliable organization. And that is not just a buzzword, not just an industry term. It is a commitment that several other industries and fields have made to become the best, to become the safest. And that's the journey that we're on. So, you're going to hear a bunch of information, and if I remember correctly, it says, "Hey, NMC does a great job, and we need to figure out how you should do more." And we get that. So I'm glad that everybody took usually we're thinking about braving the winter elements, and now more and more it's about braving the summer elements. But thank you for taking the time to come here. Thank you for expressing a commitment and an interest in your community hospital. Remember, we are a community nonprofit. We don't have shareholders, we have stakeholders, and that's everybody in this room and everybody in the county. So we are here to serve at your pleasure, so we greatly appreciate that, and we look forward to hearing Dr. Hammer's report, and we look forward to working with the Green Mountain Care Board and the administration on how we can continue to drive healthcare forward and make it affordable and high value. So thanks a lot.
Thank you. Let me also recognize that Ina Bacchus from Senator Peter Wake's office is here, and a number of others. We're here tonight, as you heard, to report back to you, the community, what we heard from you this past fall, and to fulfill our mandates that were set out in the Legislative Act 167. Those, in brief, are to conduct a data-driven, patient-focused, community-inclusive effort to assist Vermont's hospitals in reducing inefficiencies, lower, or I would say constrain cost growth, improve population health outcomes, reduce health inequities, which we've been trying to address a great deal, as has the Agency for Human Services and many others, and increase access to essential health services. The Green Mountain Care Board, my name is Bruce Hamry. I'm a physician with over 50 years of experience in practicing and teaching medicine, doing hospital and health system administration, and healthcare consulting. My colleague in this effort is Ms. Elizabeth Sutherland, a partner in the firm of West Monroe and an expert in health inequities. Unfortunately, she was not able to join us tonight. We have been ably assisted by Ms. Irene Way, our engagement manager, and by Ms. Danielle Etzel, our senior consultant. As you heard, my team and I began this journey to examine the healthcare system and hospitals in Vermont 11 months ago, in August of 2023, and we will give the Green Mountain Care Board and the Agency of Human Services a final report in mid-August. We've spoken with and listened to over 1,800 Vermonters from all 14 service areas and have spoken with many state agencies, and as Chair Foster said, reviewed stacks of reports and lots of data. Another consulting firm, Mathematica, and a team led by Dr. Arkadipta Ghosh, and have performed many of the analyses that we've used to develop options for changes in care delivery. These have been presented to each hospital and its board. The options were then amended based on our conversations with each hospital and its board. So why are we here today? We have 4 things we want to accomplish. One is to report back to you and what you and other Vermonters told us about your lived experience with healthcare. Second, we want to explain some of the problems facing your hospital, your community, the state as a whole, and indeed most of the country. Most of these, as Chair Foster said, are beyond the control of the hospital. We will show you what some of these impacts might be on your community and on the health system in Vermont writ large. Third, we want to share at a high level, not necessarily specific to Northwestern Medical Center, what some of these options are. And there are a lot. So I think, as you think about the issues that are here and coming at you, please understand there are a lot of things that can be done. And so one of the fourth purpose is to really to encourage each of you, your neighbors, your community, to fully engage with Secretary Samuelson, with Chair Foster, their boards and agencies, and the hospitals to plan ahead. Changes are coming, whether we want them or not, but we have the opportunity to plan ahead, design something that works, that enhances healthcare in the community, and so forth. Okay, so I'm going to skip this. We're going to talk about this. So this is what we heard last, I think, October, when we held a virtual meeting with you. We need advocacy on where to go and what to do. Well, that's what we're here tonight for, to start that off. Transgender Vermonters are getting specialist care. With anybody who have experience, it may be a long drive. And the EMR systems are not inclusive of transgender people. Long-term care is putting a strain on the hospital. We'll talk about that in a little more detail. Lack of pediatric access and specialists for both medical and mental health. I think you heard Mr. Wright address some of that. There are a lot of efforts there. Housing is an issue, not only for folks who live here, but also for people that you're trying to recruit and bring in. So many of these same things came across the state. Lack of housing, not enough transportation between hospitals or to or from a hospital for an individual. Many individuals who have insurance don't go to get care because the premiums and the out-of-pocket expenses are too high. Difficult to find primary care providers. Getting patients home to home from care is a challenge, and so forth. So here are the challenges generally. There are access challenges on the left side, and there are the affordability challenges on the right. All Vermont communities are facing significant challenges in access, equity, and affordability. Note the difficulties in that on getting timely appointments, transportation, major increases in both in premiums and out-of-pocket expenses, making the use of healthcare out of reach for many with good insurance. Major changes, as Chair Foster said, are required to reduce these rates of increase. There are many alternatives to providing care that don't necessarily need inpatient care in a hospital. And we've talked about that. Okay, so Vermont hospitals, as Mr. Wright said, are facing a lot of challenges. These include an inability to recruit staff, whether that is due to national shortages of physicians, nurses, and other professionals, or to a lack of affordable housing in Vermont when people can be recruited to come here. And we've heard stories from a number of hospitals where they have recruited a doctor or a nurse or a lab tech, they've come to work, they've left after 3 months of living in a hotel. And in fact, spoke with a hospital director this morning who told me he had to rent for 6 months because his contract required him to come live in the county, but he couldn't find a house. So it is a large problem. Another major issue affecting particularly small communities is that they have to recruit a number of doctors in a specialty to provide an acceptable call schedule. And the community must also have enough patients needed in that specialty to support those people. 40 years ago, an acceptable call schedule was 1 night in 2. Now it is 1 night in every 4 to 5. So if you need 1 cardiologist, you generally are going to have to recruit 4. And that's very expensive, takes equipment, and it needs a pretty large group of people to have sufficient needs to support that. So this presents recruiting difficulties across the U.S., not just for small hospitals. UVM has this problem, Dartmouth has this problem. Also, many hospitals are old. They need to replace their air conditioning, their heating units, elevators, and so forth. As Chair Foster's pointed out, they've not been able to make the needed money from their patient revenues. Additionally, some surgeries done at hospitals are done too infrequently for the staff to maintain an adequate proficiency. Many of these require not just a good surgeon, they also require an anesthesiologist, operating room staff, and often support from an ICU or some specialist. Supporting these teams with the staff and equipment necessary may require hospitals to combine their forces to provide some surgical and medical specialties in ways that support regional access without the need to travel to UVM. Of course, you guys are pretty close, right? Other parts of the state are not, or go to Dartmouth, or go to Albany, or go to Springfield, Massachusetts, or wherever. Many hospital resources are also consumed by people who do not need the services of an acute care hospital. These individuals may be waiting for a transfer to a mental health facility or outpatient care or a chronic care facility. They may need a place to live or the services of a home health agency to be discharged from the hospital or the emergency department. The hospitals are not paid for those services of those patients because it is, quote, not medically necessary. Now, the mental health and other issues, Agency of Human Services and others are working very hard on. On the financial side, the costs of the people who work in the hospitals and the drugs and supplies needed are increasing at rates higher than the hospital is paid. Recent changes in federal law and regulation will further increase the demand for and the cost of nurses and the cost of medical supplies and devices produced in China. So, for example, federal government put a regulation in place that will increase the tariffs, the taxes on medical equipment made in China. It's 0 this year, it goes to 7% next, it'll go to 25%. One of the presidential candidates is talking about a universal tariff. Much medical equipment is produced in Europe. Many of our drugs are produced in India. And so if people have to pay more for that, we all pay more for that. Insurers are also making it more difficult for providers and hospitals to be paid by requiring pre-certification of testing, pre-authorization of procedures, or sometimes by denying payment. And of course, the legislature here has just enacted a law to relieve some of that burden. As Chair Foster said, in fiscal year 2023, 9 of 14 hospitals in Vermont had negative operating margins. If you look back a year before, and that total is 11 out of 14. An operating margin is like the balance in your checking account. It reflects the income from patient services minus the expense of providing those services. When that's negative, it makes borrowing money expensive and difficult for the hospital, and it makes the financial sustainability of the hospital problematic. Now, as Mr. Wright commented, all the hospital directors who I've met, and they're very good people, they know what they're doing, all of them are working very hard to have a sustainable operation and to keep the hospitals in the state going. Not-for-profit Vermont health plans are also not making money. They are tightly regulated, and their premium increases are driven, as Chair Foster said, by paying for the care you get, paying for the insurance, the pharmaceutical drugs that are used, and so forth. Additionally, they are required to maintain reserves so that they can continue to pay for the care you require, and these reserves are becoming alarmingly low. This shows the costs of rates of increase. Median household income in Vermont over the 5-year period 2018 to 2022 increased about 22%. The charge increases approved by the Green Mountain Care Board at the request of the hospitals was about 38%. And the cost for one of the plans on the state exchange rose 108%. Others did on the state exchange apparently did not rise at quite the same rate. So, steps need to be taken, plans must be made and implemented to change these rates of increase. How did we approach these issues? Well, I'm a doctor, we did what doctors do. We took steps to make a diagnosis, what are the causes? We took steps to try to formulate a prognosis, a way of looking forward, what's the future, and what are your options? And then the treatment, what are the options, what are some of the likely outcomes? There are many of these to choose from, and we'll talk about that. And at the end of the day, you as the patient and your hospital and the board and many others get to choose among those, right? You choose whether you want penicillin or something else. And that's something that we really need your involvement in. We use tools and data to make the prognosis, and the forecast depends on some certain assumptions, and I'll talk to you about what those are. So this is what we've done in part. We've met with a lot of folks. We've had a lot of people in meetings. We've totaled a lot of organizations, and the numbers are not important, but we have tried our hardest to be both patient-centered and community inclusive. And we've particularly sought out groups suffering from health inequity and other having other health or needs. Now, and a key point here is that you really like to have preventive care and primary care in the community. That's at the top is the root of the issue. And when you don't have those, or they are limited, then care is squeezed into the more expensive areas, into the emergency room, into the hospital, and as people don't get early care and intervention when the disease is mild, it gets worse. And the emergency room people tell us routinely, people are sicker when they come in. And when they're sicker, they may have illnesses beyond the capability of the community hospital to care for, so they wind up going to a much more expensive place to get care. So one of the things that you'll need to address in this process that you're embarking on will be how to work and make more of these things available. And as I've said, AHS is working very hard on this. Using all this information, analysis, reports from prior state commissions, and consultant reports, we constructed a financial forecast or prognosis. This makes certain assumptions which we have tested with many people. I will note not everybody agrees on this. Shown on the left in those boxes are the increases in rates approved by the Green Mountain Care Board. And they're for a Northwestern Medical Center. So you see the rates requested were really pretty low. They were mostly approved. 2021, a little bit of a variation, but significant numbers, 13% in 2021, less in 2023 and 24. In the graph on the right, you see the operating margin for the hospital. To the left of the gray bar is previous. The gray bar represents performance in 2023. We took that as the base year. So we started our forecast, the one I'm showing you, from that year. Notably, this has two assumptions in it. The first is on revenue, which this year the Green Mountain Care Board is trying to cap at 3.1%. So that is, that's the Consumer Price Index, plus 1%. The cost increase, we put 5% in. I think that's low. Around the country, it's more like 7 to 8%. But several hospital administrators around the state said we're trying to hold it to 5%. And so, as you would expect, if your costs increase above what you're getting paid, things get worse. And I will say, these are not good numbers. They're not good numbers for any hospital in the state. I showed some of that data Monday to the Green Mountain Care Board. And as I noted, the hospital folk are working very hard for this sort of thing not to happen. But as I have also mentioned, there are things that have happened in the last 3 weeks that are not in these numbers. The feds just cut physician payments by 3.2%. So that's going to hit every physician employed by a hospital and every physician who practices. The nursing home regulations were changed, which needed to happen, but that's going to result in more nurses being needed in nursing homes. It will improve quality. It will further stretch the deficit in RNs and obviously increase the cost of hiring RNs. And I mentioned the tariff. This slide shows the approval ratio of the Green Mountain Care Board to hospital requests. Now, this is statewide, not Northwestern Medical Center. I want to call your attention to two things. One, if you look at those blue bars on the left-hand side at 2023, the numbers at the top, the 2.1, are in billions of dollars in Vermont healthcare. On the extreme right in 2024, that's 3.6 billion. So that's about a 60% increase over really an 11-year period. And the average rate of increase is about 4.9%. At the bottom, of the total dollars requested by all the hospitals in the state, a little over 99%, and in some instances 100% were approved. Now recall, the Green Mountain Care Board can only influence and control the commercial premiums, right? Medicare is federal, Medicaid is a combination of federal and state. And so it's a small proportion, but has big impact. Okay, so what do hospitals do? Well, hospitals have three ways to improve operating margin. One, you can increase the charges you asked for and therefore the money you get paid. You can reduce your operational costs, which everybody's working on. Or you can increase the volume of profitable services. And Chair Foster commented on this. You do more orthopedic surgery, more surgery of some other kind, or you cut services that lose money. And you see that going on around the country. We're not seeing that in Vermont. And if none of those things work, you ask for money, right? And that money comes from the state, it may come from a donor, it may come from a grant you get from somewhere else. Hospitals, as I've said, cannot solve this on their own. They need, and everyone needs, some different and innovative approaches to reduce costs and improve services for the community. I've given some suggestions on Monday to the Green Mountain Care Board. I'll show you some of those. They are all things that people are already doing, many of them here, as you heard from Mr. Wright, but in other parts of the country, in other parts of the world. You may be aware, at least I'm seeing ads in Massachusetts. Last week, Amazon started offering televised consultations and treatment at $49 a piece. So progress marches on. But the point is that solving these challenges in Vermont is going to require concerted, sustained transformation, which Secretary Samuelson and the Agency of Human Services will lead with the Green Mountain Care Board and the legislature and many others, and your active involvement in that process is needed. So where do we go from here? We made a large effort, back up one, a little ahead. We did make an effort in our analytics to see if addressing the problems of potentially avoidable ED visits, that is people who could have gotten care at a primary care office or an urgent care center or a community-based mental health facility, would help, whether reducing preventable hospital admissions would help, and whether reducing the number of boarders. These are people who needed care, got it, were ready to go home or go somewhere else, and just couldn't get there. And we wanted to see if that would free up enough space, enough capacity, so that the hospital could bring back the people from your community and from your county who were leaving the county to go somewhere else. And this is a generic problem in the state. Roughly $800 million leave the state of Vermont for medical care, whether that's commercial dollars or Medicaid dollars, Medicare dollars. Those are things that could be brought back to Vermont. People can get that care here, and they bring dollars and jobs back. So a major design principle for us was to get care back to Northwestern Medical Center, as it had capacity that could be freed up, and it had the capability of its medical staff to do. And you are lucky here, you have a pretty capable group of doctors and staff. And the second design principle was to get people out of the very expensive academic medical centers. And I can vouch for that, I ran one. So we did double check the capacity and capability of the staff with the leadership. And after a lot of analysis, sadly, these measures improved revenue, but also increased expenses somewhat. Did not generally in the state offer a significant improvement in those projections. Now, I think the group here will comment on that. So, we shared all this information with Mr. Wright and the board. We had a very good conversation, lasted a long time, and they will make decisions based on that and what they hear from you. I've noted there are more headwinds coming. So where do we go? As I said, hospitals can't do this by themselves, and you're going to need to work on it. So what does charting a path forward look like? First, recognize the current situation and the adverse headwinds you are facing. As Peter said, the Marines would term this adapt. We have discussed this earlier. Second, change what you can and build on the many current efforts underway to improve access, improve equity, and reduce the costs of health care. The Marines would call this survive. You push it further so that this happens, and the Marines would call that overcome. So it's a good motto. Done in the right way, these changes can ensure that redesigned services have stable financial and a stable operational future going forward. Abraham Lincoln said, "The most reliable way to predict the future is to create it." Shown here on the left are the mission statement for Northwestern Medical Center and the service needs for your community that you and the hospital put together in your community health needs assessment. You notice access, affordability, community connectedness, and safety and belonging are principal efforts on this list. This slide shows you part of what Northwestern Medical Center is doing. They are piloting a medical respite program in the region. for people that have chronic care needs like multiple sclerosis. Family takes care of them at home, needs some time off, the hospital can provide that. They are part of, with you, of the Accountable Community for Health plan that designs, they're investing in health equity in a number of ways. They're collaborating with a number of other institutions, UVM for trauma and cardiology, Dartmouth for telemedicine, and Ovation that helps with patient recruiting and other services, and so forth. They're active in a group purchasing organization. That's a way to reduce the cost of supplies. So, changes at both a hospital and a health system level are required to meet both current and future needs for health care. These needs fall broadly into 5 areas: embed updated and modern information technology in hospitals, offices, homes, and other places where people receive care. Second, provide housing for Vermonters and for others moving into the state. Some in Vermont have no house. Others are living in houses without water, without electricity, or heat. This is arguably the most urgent need Vermont has, not only to address inequity, but also to provide a safe place for people to receive appropriate care out of the hospital. Adequate housing, whether a single dwelling, mixed income housing, group housing for those with mental health or other needs, or assisted living facilities, is required to reduce the crowding in hospital emergency rooms and the number of people staying in hospitals and mental health facilities because they have no place to go. And there is a state program, I think it's Choices for Care, which is aimed at doing this and allowing people to age in place. Transportation for people to and from medical care, to pharmacies, and to other places needs to be enhanced and available in the evenings and on weekends to help people with urgent care needs get to and from urgent care or the doctor's office or the emergency department. One of the things we find is that a lot of people show up in the emergency room, get care, and then can't get home in the evening. So they wind up spending the night. And often, they may spend the night on a bed. That means an emergency room backs up. Emergency medical services, which are largely staffed by volunteers, need to be combined, linked tightly to the hospitals, and made into a full-time professional workforce. They also have a lot of skill. Mount Scottney uses them in the emergency room. Some others use them along with nurses. Other places around the country use trained emergency medicine technicians and paramedics to deliver care in the home. One of the EMT folks commented to me that 20 years ago when he started work, you showed up for 12 hours, mainly sat in the building with dinner and taken a nap, maybe got 1 or 2 calls a night. Last year, and that group 10 years ago did 300 calls a year. Last year they did 2,200 calls. And he said, so now you show up at night and you're up all night and then you're supposed to go to work the next day. So those men and women need some help. In the planning process, which will be described shortly, hospitals and communities also need to design a system in which there are regional referral centers, each containing an area having a sufficient population needed to contain and support the physicians, staff, equipment, and other services needed to provide high quality, efficient care for specific diseases or conditions. Work we have done and shared with each hospital suggests there is and will be sufficient need that some of these centers could be supported in various parts of the state so that people would not have to travel to an academic medical center, UVM, Dartmouth, Albany, Boston, to obtain that care. In the system that we hope will be developed, all providers, primary care specialists, dentists, EMT services, hospitals, social providers, and so forth should have their payments linked to one another and to achieving common goals: access, quality, efficiency, appropriate use of resources, and equity. Let me be clear about efficiency. This means doing the right thing at the right time, not forgetting to give a vaccine, or ordering a more expensive test when another may be adequate and less expensive. As noted below, we want a future healthcare system in Vermont that focuses on earlier identification and treatment of illness, and patients being able to obtain care at the most appropriate level in their home, in their community, or close by. There are many potential options for your hospital and your community to work together with other communities and other hospitals and AHS and Green Mountain Board, the Green Mountain Care Board, to develop new programs and expand existing ones. Some of the many options for care are shown on the left. Telehealth is currently used by many hospitals in Vermont to support their emergency room staff with neurology, cardiology, and in one instance, psychiatry consultants. And you've heard Mr. Wright comment on that. These need to be increased in number and paid for. The consultations are very expensive and the reimbursement doesn't always cover that. Telehealth can also be used for monitoring patients in the hospital and for monitoring patients to see how they respond to treatment at home. There are rural outreach programs that are possible. Several hospitals can combine resources to equip and staff mobile vans to take care to rural communities. Examples exist of mobile dental treatment, mammography units, primary care clinics, mobile screening for osteoporosis, and other means. Primary care providers and urgent care clinics could expand their hours into the late evening and on weekends to allow working people and children to access care after work and in the evening. Now, several have been trying to do this, and some of them have had to pull those hours back because they don't have staff. So staffing is a big issue for this. All of these are possible. Many are underway or in some stage of development. As Vermont's capabilities improve for the transmission of medical information and the state expands broadband internet to more communities, the ability to deliver more health service and support to people's homes, to primary care offices, and to further interconnect hospitals becomes elsewhere. Expanding this capability to allow people to be seen in their home would be an advantage. We've mentioned for people who lack a car or other transportation, taking care to them can solve problems in both equity and access. We've talked about EMS. We've discussed the need to include develop some potential regional referral centers. And another critical need is programs to address the specific needs of small numbers of people, smaller numbers who have multiple medical and physical needs. These are the dual eligibles. On the right side are listed some of the steps in translating this future vision into local changes and to implement them. And I noted at the top that the secretary, I believe, may have started to convene the medical centers and others to design this process. So there's a process to involve everybody, to design the process that's optimal for you, choose among these options, to conduct then a look at, do they meet the needs of the community? Are they fiscally and operationally sustainable? And then to conduct statewide planning discussions, potentially confirm a plan and do it. The Agency of Human Services has many programs underway. There's not time to go through these in detail. I did in an earlier session with the Green Mountain Care Board about a month ago, and would invite your attention to that. I would call your attention to the large efforts in mental health and substance use support, and in the supportive care for the elderly. Green Mountain Care Board has also been working on this hard and for a number of years. So where do you go next? How do you get involved? Change will not happen by itself. So designing and implementing an improved and sustainable delivery system for this community and others requires the active participation of everybody in this room, of other hospitals and communities in the state. This is shown by this photo of an Amish community raising a barn in Lancaster County. Working together, much can be accomplished. You have many more tools available to you than the farmers in this picture. Broad changes in custom and practice will also be required across the state. What affects one community affects all. Whether an unplanned, unanticipated disaster in one community, whether a flood, a pandemic, or a hospital closing, has impacts throughout Vermont. As I discussed a while ago, the financial projections for many hospitals in the state show diminishing financial stability over the next 5 years or so. Therefore, your time horizon or runway to design and begin to implement change is relatively short, not instantaneous, but it's certainly not too much more than 5 years. So the airplane runway on the left is 10,000 feet long, 2 miles. The airplane runway on the right is 900 feet long, with a cliff at one end and an airplane hangar at the other. There are 8 pilots in the world certified to fly into that airport. It's on the top of a mountain in Bhutan. So you don't have a 900-foot runway. It's longer than that. But it's not 10,000 feet, right? And so really what I've hoped we're doing is to, number one, help you understand a little bit about what the challenges are. Number two, what can be done about them. And the list of options is considerably longer than what I've shown you. And most importantly, to be engaged as citizens in the community, along with your hospital and the Agency of Human Services and the Green Mountain Care Board, to be engaged in this process, because there will be potentially some difficult choices to be made, and you as the patient need to be involved in making the choices. So thank you for your attention. And I'll turn it over to Mr. Wright.
Thank you, sir.
Peter.
If you're sitting next to somebody who spontaneously sweats and starts to get nervous every time I grab the microphone, it's probably a member of our senior leadership team. I always get a little bit nervous when I have a hot mic in my hand. thank you very much. Let me just start and where we started, which is thank you very much for taking the time to come out tonight. What you heard tonight is intense and it's dense. And please be reminded that change doesn't happen without discomfort and occasional pain. It will be uncomfortable for us to change. It will be uncomfortable for us at Northwestern Medical Center. It will be uncomfortable in the community as we reset expectations. But it's all about continuing to produce safe, high-quality care at a price that we can more readily and increasingly afford. That's the goal. You heard a lot tonight about partnerships. And I think one of the things that is really great about this community is we have incredibly strong partnerships. You'll see folks from NCSS in the room today, folks from the Notch in the room today. You'll see our legislators in the room today. You see the administration in the room. We have partnerships with all of these people. 25 years ago, when I first started in this field, it was hospitals were going to own everything. And probably one of the best aspects of Northwestern Medical Center is we don't think we're the best at everything. We think we're really, really good at a part of the healthcare spectrum known as hospital work. But we also know that we can't do that alone. And so those partnerships are what we lean on and rely on every day. You heard that, every business, and this is a business whether we like it or not, has to grow. But our goal is to make that cost per encounter smaller. We need to do more, right? We have the capacity to do more. We have the capacity to do more. We can do it at a better rate than most others, and it will help our organization. So we need to do more. We need to do more for our community. We need to make sure that fewer and fewer people leave the community to get care for the work that we do. The other side of that is we also need to continue to reduce our costs. And that's why we're really proud that we are a founding member of the New England Health Collaborative Network. That is a group of independent hospitals that have come together to do some really seemingly basic things, but really important. We are now, my favorite expression, we are now buying our fuel oil together. We are aggregating our spend on healthcare benefits together. When Copley Hospital bought a CAT scan machine, and we were buying a CAT scan machine, we reached out to them and they helped us, and we negotiated a price for the same CAT scan machine so we could get a lower price. We are a group of independent hospitals that are looking at all of our spending, everything that we spend money on. How can we pull that together to get a lower cost on the things we're already going to buy? Whether it's fuel oil, whether it's a CAT scan machine, whether it's Band-Aids, whether it's traveling nurses, whatever it is, we're trying to get what we need at a lower price. And we're doing it beyond our own walls. And we're being very creative and breaking down the walls, and now we've created a network within our community. So we're connecting with primary care health partners, we're connecting with home health, we're connecting with Notch, we're connecting with NCSS, and we're trying to figure out how we can save them money as well. And so that network is going to reduce the cost of care outside of hospitals by over $1 million this year just through that effort. Something that hasn't been done in this state for decades. So we are, again, at the leading edge of thinking out of the box, not only about how we can increase our revenue but lower the per unit cost, right, as we grow, but more importantly, how do we keep our expenses down? Because remember, the goal, provide the right care in the right place at the right time. We have partnerships through telehealth with Dartmouth-Hitchcock, and we will continue to leverage those partnerships. We have an outstanding relationship with the University of Vermont so that we have a place to transfer patients when their care needs are beyond our scope. They're right down the road. Our Chief Operating Officer, Jonathan Billings, loves to say, we have the best NICU in the state. It's just 22 miles down the road. I think I got that kind of right. So partnerships are incredibly important. Our local community partnerships, our partnerships with the academic medical centers, and again, our partnerships with the state as we go through this change. We will, again, be at the leading edge of that. So lots of information to digest here. I would encourage you, if you have any questions, My office, our team, we're always open to sit down with you and help you explain how this might impact you. If you're a business leader and you're thinking, how do I just reduce my healthcare costs next month? We have ideas on how you can do that. We can reduce your healthcare costs next month. This will be a tough and a long road to change, and like anything else, we will probably overestimate what we can get done in the next 2 years and underestimate what we can get done in the next 10. So thank you again for coming out. We appreciate it. Thank you for your work, sir. To all the folks that are here, we really appreciate it, and we're ready to take the next steps.
Thank you. Thank you very much. I think you've heard a lot going on. We're also ready for questions. I would remind you, please, the presentation will be available. Encourage you also to go to the Green Mountain Care Board. If you don't get to make a comment or remember something on the way home, you can go to the Green Mountain Care Board website and make a comment. We do look at those. We do take them into account. So, questions or comments, please. I'd like to ask you to hold them to short. Sir. Oh, there you are.
Stay over town. Thank you. I'm on Medicare, and I know what you're doing to reduce costs, but I would say if Peter's looking out his window and I'm coming, there's a loss leader. I get with Medicare reports, the hospital bills $200, they approve $10, Blue Cross Blue Shield covers number 5. How do you cope with that in spite of all the work that you're doing now?
Well, you're right, and there is Medicare, as you know, sets the amount they're going to pay, right? And there's such a thing in a hospital called a charge master. All right, and that's based on calculation the hospital does of what it costs, and then they negotiate some amount of payment different than that, hopefully that makes money. And so when you and I get that same report, right, you see this huge cost or this huge charge, and then there's a write-off for what was negotiated. Usually it's half or more. And then there's the piece that the insurance company pays, and then what you and I pay, right? And it depends, obviously, on what your insurance is. If you're on standard fee-for-service Medicare, that's 20%. If you have a Medicare Advantage plan or something else, it's less, maybe considerably less. If you're in insurance, then the issue is, what does your insurance plan, your employer, for example, if they're paying part of the bill, what is the deductible that you have to pay through the year, or what's your copay? And those deductibles, as I think Chair Foster commented on, keep going up. Right. And I see that in what I'm paying too.
Total income from these various...
I'm sorry, please.
Does your total income from these various sources equal your costs?
The total income of...
From your Medicare, from the private insurance companies,
yes,
so forth, do they equal what you actually spend to take care of me?
Well, no, and this is a key point, thank you, and I appreciate your clarifying here. No, Medicare typically is only paying at the range of 80%, maybe 85% of what it costs. Nationally, Medicaid pays around 65%. Now, it may be a little different in Vermont because you have some, but typically those are the shortfalls. And then what I used to do as a hospital director, and what everybody else does, is you try to make up that deficit from the commercial payers, right? So you get pretty high rates from the commercial payers, and in part, the amount of those dollars depends on how much of your business is from commercial payers. And so when you look at a hospital in a large city, or a place that has a lot of people and a lot of people on commercial payments, your proportion of total hospital payment from commercial might be 20%, 40, see places it's 40%. Well, if you have 40%, you don't have to charge as much to all those people, right? So, it's a quirk of the complicated way healthcare gets paid for in the U.S. And it's, in a sense, it's just as much true of any healthcare operation, whether it's a not-for-profit hospital or a freestanding ASU. Unfortunately, the docs don't have the ability to negotiate very well. So they typically wind up on the short end of the straw. Was that okay? It helps? Okay. Other questions or comments?
Good evening. I'm State Representative Lisa
Yes.
Hango. I represent the district on the Canadian border, quite rural. I'm really concerned about my constituents who are at least 45 minutes from this community hospital here.
Yes.
And I'm really intrigued by your regional referral centers.
Yes.
Can you expand a little bit on what that would look like? Are they the FQHCs perhaps? Are they the community hospitals? What are you envisioning?
Well, I think the question, as I commented, it's hard to recruit one or two docs, right? I mean, my granddad was on call every night. Okay, I grew up it was every other night. Not anymore. I mean, it's not a reasonable lifestyle. It's bad for your family, all that sort of thing. So the idea of a regional referral center, which other people have done, I give you an example. There was two hospitals, one in Texas, one across the border in Oklahoma. They were both having a problem. They each did a little bit of orthopedics and a little bit of this, and they got together. Nothing the FTC would like to see, but they said, why don't you do this, we'll do that. And so they got enough patients to support the specialty service. So what I'm really thinking about, and again, this is a process and a lot of people need to think through it, but with the data we've looked at, there are enough volumes for a number of things to have some of the hospitals come together and say the same thing. We can do this. We can do it as well, at Northwestern Medical Center or, Copley or, somewhere else, that we can be really good in this and we can have enough that we can have, I'll take the example of a machine to do minimally invasive surgery. And they're expensive. They require a big operating room because there's equipment. They require more air conditioning because it generates heat. You got all this stuff. It takes a team to run them. But you can do that and use it for general surgery and women's health and other things. And there is also a concept which the American College of Surgery has put out of what's called a Center for Emergency General Surgery. So that if you developed one or two of those around the state, every hospital might not need to have a general surgeon on call all the time. And there are, and this depends on transportation, right? Another piece of this is you can supplement the FQHCs and the primary care offices with telehealth consultations. So you can get a neurologist to talk to you about a patient in your office. And we actually tried this at Penn State in 1992. And at that time we had to use the available connections to the state police units out and around the Commonwealth. And it required scheduling and all this other stuff, but it's simpler now. And so you could do that. I don't really think you're going to have a specialized treatment center in a very rural area, but there are ways to dramatically improve that service. And like I said, you can we put mobile vans together to go out into rural communities to do screening for osteoporosis, to take primary care people out, just like the old book vans, the mobile libraries used to do. Shows up to Crossroad or the local school, people don't have to travel 10 miles. So I think all of those are options that can be considered. They may need some changes in financing, okay, which again, you've got folk here that have some say in that. You've got, as you are, a legislator, and you all have made good, a number of good changes, but those are options that are out there. One that I put out that somebody thought was magic is that there is a system which is in the process in Indonesia. They have 1,000 islands. They do not have pharmacies in all those places. People still need penicillin and this and that. So they are in the process of figuring out how to put, in a sense, pharmaceutical dispensing machines out there. Now, you could do that in a hospital ED, right? You won't dispense, narcotics and scheduled drugs. But, if people need an antibiotic or they need a blood pressure treatment or something, and the pharmacies are closed and the nearest one's 30 miles away, you could actually do that. Might require some changes in the pharmacy regulations, but those are all issues that can be worked through. So I hope that helped a little.
Dr. Henry, can I just chime in?
Please.
We deal with this today, right? If you come to NMC and you need general surgery, we have full service general surgery 24/7. Every day there's somebody on call. If you need a pulmonologist, right now the pulmonologist is only available every 4th day. If you need an ophthalmologist in the emergency department, every 4th day, right? So we provide these clinic services day in and day out. Some of them will also do inpatient consults, but maybe we can't provide call every night. So I think what Dr. Henry was saying is part of as we scale our expectation is you may be able to get some services during the day, you may be able to get some services in the clinic. Sometimes it'd be available for an emergency department consult or a surgical consult, sometimes not. So there'll always be services in the full spectrum. Orthopedics, we've got enough orthopedic surgeons that we can provide that consultation every day. General surgeons every day. Pulmonologists, pretty soon will be every other day. Ophthalmologists, pretty soon will be every other day. But right now, it's 1 in every 4. So those are the kinds of scale that we look at, and you have to look at the environment, right? You need a neurologist. We don't even have a neurologist for outpatient. If you're an inpatient, we can kind of do that through telemedicine with Dartmouth-Hitchcock. So, it's about having elastic expectations, if that makes sense. Does that explain it a little bit?
Thank you. No, thank you. And just to say you're fortunate to have all that. There are a lot of other little hospitals around the state that don't have that, which is also, what we're worrying about. So, other comment, but yes, ma'am.
Yes, my name is Dorothy Goldbooth and I'm from St. Albans. I have a question for Owen Foster. And you mentioned that things have changed rapidly just in the last 3 weeks, and I have some questions about some of the changes. And one of them is that Vermont has now been chosen to be one of 3 states to participate in this new experimental 11-year program. Is this a done deal? I don't think we should do this. It's just an experiment, and I think it's a waste of money. And I hope it's not a done deal. Is it a done deal, and why don't we have any say, the people of Vermont? If they just tell us what we're going to do?
I can answer that, but I'll defer to Secretary Samuelson. It is not a done deal. The state's evaluating whether or not it's the best step forward. There's a lot of pros and cons to it, and they're being evaluated. And second, the state.
Sorry, it's a good question, and the answer is it's not a done deal. We were accepted in the application to pursue it further. The state is currently evaluating the pros and the cons and whether or not it makes sense for the state to pursue it.
They mentioned $12 million, but that's peanuts compared to what you've been talking about tonight.
Right, so that's funding for us to evaluate the program and come up with some of the infrastructure that we would need to then enter the agreement and actually do it. So we're evaluating, I think it'll be spring of 25 when we'll be making the decisions. So between now and then, there's a lot of opportunity, a lot of care board hearings and meetings for people to opine and share their thoughts on whether or not the state should pursue it. But no, it's not a done deal.
Good, I'm glad to hear that.
The negotiation will be starting soon, and how that turns out will have a pretty big impact on whether it's beneficial for the state.
And I have another question, and I see that Mike Fisher was, yeah, where's Mike Fisher? He went back there. Just recently, it was announced on the television that low-income people or people who are of a certain income bracket, and I don't really know, they mentioned $75,000 a year, will no longer have to pay any hospital bills. And I want to know what the details of this is, and how this is going to help the hospitals. And Mr. Fisher, I'm angry with him because he said low-income people don't pay their hospital bills. And we will certainly do. And we have to pay the top rate. So what is the details? Here we have our legislature keeps adding more and more people to get free care, which only makes it more expensive for the people who have to pay. So that's not helpful.
Well, let me just comment. All hospitals have what would be called a sliding fee schedule, right? So that people who are in poverty, and there federal definition of that, and many hospitals will go up to 300% or 150% of the federal poverty level, and then can either forgive the bill or arrange a payment schedule. And there are federal rules about that. It cannot account for more than a certain percent of income, and it cannot last for, I've forgotten, I think it's 3 years. So there are a number of protections in this, and it is one of the expectations of not-for-profit hospitals. It's one of the reasons that they are not taxed, for example. I can't comment.
Dr. Hammer, I can.
Yeah, please, Peter.
So we have a financial assistance program. Every hospital, I'm looking at Devin, has the same financial assistance program. And so if you make upwards of 300% of the federal poverty income level, depending upon where you fall, you might get 25% off your bill, you might get 100% off your bill. So if you work with the financial counselors, anytime you get care, you'll know in advance where you fall on that, and we are always overly excited to make sure that people fall into that program instead of what we would call a bad debt program. So we're constantly encouraging people, help us understand what you make so that you can apply for this program so that we can write these bills off. We have no interest in kind of chasing down folks who fit into this scale. We're more than happy and excited to write that off. That's part of our commitment to the community. That's part of us being a nonprofit and a charitable organization, and that's part of our commitment back to the community. And I can say every hospital and all of the community, one of the beauties of Vermont are there are no for-profit hospitals in the state. They're all non-for-profit hospitals. And so I think that's really important. And if you haven't been afforded that opportunity, then I will personally help you make sure that you get care with those folks.
Because my son has a very high bill. He became incredibly ill.
Our team sits at the ready, but we don't know what anybody makes until they
He's
tell
having to
us.
pay a lot of money,
Yeah.
even though he had good insurance.
Well, I'll make sure before we leave, you get my information, I'll get yours, and if your son qualifies, we'll make sure that
I'll have
happens.
him contact you, because they did put him into bad debt, and he was paying. He was paying his bill, and he still got. So.
Yeah, I mean, look, we every single day we make payment arrangements with our patients who don't fall into that program, and folks, some folks pay us $25 a month for until it's all settled, and that's fine. We have certain criteria that we follow, and that's part of the statewide.
I just want to say that we've always felt we had good care at the Northwest Medical Center.
Good.
There's no problem there.
I kind of wanted to get back. I want to give Secretary Samuelson a moment to comment about the what's called the AHEAD model. If you wanted to comment on that.
So I want to echo Chair Foster. What we know is that the AHEAD model, as it comes out, while it is new at the federal level, it's in many cases a continuation of the work that's happened here in Vermont for the last decade. But we need to assess whether it is the right model for Vermont. And one of our major goals of the model are to bring federal investments into the state that would help to support the work that we're doing and the work that's been outlined tonight. And that's part of our assessment. And while there's there's $12 million in for some of the assessment work, there could be as much as $225 million worth of investments that would both continue in Vermont or would be added to the work that we're already doing. But we need to assess whether we would be able to leverage and access that money to help drive this work forward. So we don't have to make a decision for a year. We will be going into the negotiations for that, and what we will be doing is working on behalf of Vermonters to make sure that we get the best deal that we can so that we can drive the work that we've seen tonight forward.
Great. Thank you. Welcome. Thank you. Other questions?
Hi, my name is Erin Creeley. I'm a St. Albans resident and an NMC board member. I'm really appreciative of this presentation. I think one of the pieces that Peter has talked about and others have talked about tonight is the partnerships in our community. One of the benefits or the blessings I think that we have in Franklin and Grand Isle County are the community organizations and really the grassroots and small nonprofits that are meeting the needs of access and affordability for our community members, like Martha's Kitchen, Abenaki Nation, Missisquoi, Bridges to Health. There's many others, including Cider out in the islands. What I'm hearing from those community partners is they're facing funding cliffs, either in the next year or 2 years down the road. There was a lot of support during COVID, but less support now that COVID funding is drying up. Or there was other infusions. And for small organizations, especially grassroots organizations like a food shelf, they're often volunteer run. They don't have the administrative capacity to apply for grants and to manage larger organizations in the need. But a hospital can't be a transportation organization, it can't be a food shelf. We have those in our community. And one of the pieces that I feel like has been missing from healthcare reform in the last decade plus, not just in our state but elsewhere, is thinking about funds that not just impact the system that delivers care, but the folks that are receiving the care.
Yes.
So thinking about caregivers at home, both for children and for folks with disability, folks that are older, sandwich generation, and then also thinking about the smaller organizations that provide transportation, that provide meals and housing support. So I would love that in whatever model we come up with, that we're also thinking about how can the funds and the value-driven funds that may be generated go back directly to the community with low administrative barriers to access those funds and use them for the community and the public. So that's a comment. And then a quick question. There was a figure that was delivered either in your presentation, Sarah, or in Mr. Foster's around the amount of dollars leaving the state for care. And I'm curious if we know what those dollars are. Are they snowbirds getting care when they're in Florida? Are they folks seeking care at the Mayo Center? Are they folks just crossing the river into Dartmouth? So I'm just curious if we know where those dollars are going and what the quality of those dollars are. Thanks.
No, thank you, and thank you particularly for the comment. I mean, those have been issues that we're quite aware of. They are in some of the more detailed recommendations. Yeah, you know, I mentioned housing, transportation, food, I mean, other things clearly important. And we all are very cognizant of and appreciative of all the work that you and your colleagues and the others in the community are doing. As to the dollars leaving the state, I don't know specifically about snowbirds. I do know that a lot of it is spent in the surrounding states, and obviously a pretty large amount goes to Dartmouth. Now, I would have to add that Dartmouth is not the highest rate place that Vermonters go for care. And certainly on the east of the mountains, that's where most of the folks in the state go for their specialty care. Again, a lot of that is within the capability of the hospitals in that part of Vermont. And particularly as some of these other things can be done to assist them with specialists and other things. So I think there is an opportunity to bring some of that back. And I think you'll find in the process that will go forward that, you know, in 2022, I think it was, the total state dollars on healthcare all in were something around $6 billion. So there clearly would be money that, as programs are developed and shaped and all that, that might be moved around. But I think, again, that's a group decision, right? So, but thank you for the comments. Others, please. Yes, sir.
So, first I'd like to commend Peter and the whole gang at NMC for all the work they're doing, trying to adapt to what's going on, you know, and the changes in healthcare as it is now. I was struck by the projection for margins showing a continual increase in negativity of the margins, and it seemed like that was based on some generic numbers, 5% cost growth, 3% expenses. But does that include something like UVM proposing a new surgical center, which could suck, you know, surgeries from our local hospital out? Because, you know, you kept using the phrase things that are beyond our control. And if we're going to do something about those decreasing margins, it seems to me that the state, the board, needs to do something about the things that are beyond our control. And I'm concerned that somebody from Ridgeford is no longer going to be a 45-minute commute for them. It's going to be an hour and a half commute for them, because it seems to me that these big centers are trying to put our local hospitals underwater. And I'm afraid that if that surgical center is approved, we could lose NMC if they can't make margin.
No, understood. And I think I can't comment on the new whatever, because I'm not involved in that. And these projections do not include that. They were done before that proposal was submitted. So thank you for the comment. I would comment that UVM and Dartmouth have both begun to move some of their services out into the community. So for example, we talked with gentleman at Mount Escutney, and Dartmouth is moving 5 ophthalmologists out there to do their cataract surgery. UVM is moving some of their surgery to CVMC so that they can offload their ORs and get people back to the community. Same thing at Porter with some of the services there. So it's not as vigorous as I'd like it, right? Or you'd like it, but it is something that's starting to be done. In addition, for example, I've forgotten the exact number, but UVM's doing 3,000 deliveries a year or something, big number. A lot of that comes from Burlington, fair enough. There are also a number of women who make the choice for whatever reason, or who are sent to UVM who have normal deliveries, right? Healthy baby, healthy mother, no problem. And I will tell you, obstetrics now, I'm not an obstetrician, first thing to say, but there are very few surprises in OB now, right? When I trained at one of the World Centers for Heart Surgery, and we'd get a call at 10 o'clock at night from a hospital 300 miles away in Texas. We have a blue baby. We're putting them in an ambulance. They'll be at your place in 3 hours or 4. The whole scrub team had to get ready to do the intricate heart surgery to fix that. Now you diagnose that with an ultrasound. The surgeon plans the surgery 3 months ahead. They bring the baby in, mom is maybe induced or has a C-section, whatever. Baby is delivered, baby goes straight to the OR and gets fixed, all scheduled. So the point is that one could, by offering more OB services in some of the surrounding communities, keep that care and free up UVM for something else. Okay, do it at lower cost, do it closer to home, and there are places that do that. But again, you always have individual choice. Mom and dad get to decide where this is going to happen.
Dr. Henry, can I?
Please, yes, please.
I think I can answer what your question is a little more specific. So the numbers that are out there are accurate. I'm going to put them in a broader context. Part of what we were asked by the Green Mountain Care Board is to submit our rate increases going back to, I think it was 2011? It was a stretch of, maybe it was, 2011, I think it was 13 years. The average, the average rate increase for the state of Vermont over that period of time for all hospitals was about 4.5%. The average rate increase for Northwestern Medical Center was 3.85%.
Right, we showed that.
We had the lowest average rate increase over the period of time the Green Mountain Care Board asked us to kind of evaluate. The chart that you saw that was disturbing, and I agree it was disturbing, was our financial performance going back, I don't remember exactly how many years, but I can tell you that Northwestern Medical Center's financial performance up through 2015 was very strong for decades. Yeah. NMC has always been a well-managed, well-run organization that had strong financial performance. In 2015, NMC asked for a 0% rate increase from the Green Mountain Care Board. Because of the margin that was made that particular year, the Green Mountain Care Board, and again, Chair Foster was not there, so he was exempt from this, said no to the 0% rate increase and did an 8% decrease. Mm. Since that time, every year, we have lost money. Now, is it a direct correlation? It's not a direct correlation. Is it a big part? Absolutely 100%. So, the flip side, and if I were Chair Foster, he would jump up and say, yeah, but that means your insurance rates in this area have also been lower, and that's true. And that goes to that tension between how do we keep your insurance, what you pay, what comes out of your check every week, how do we keep that low, affordable? We've used affordable, and it's like, is there anything affordable? If anybody tried to buy a car or groceries or gasoline, affordable is a word, quite frankly, I'm not sure we can use anywhere these days. But that's our goal, is again, how do we lower that unit cost? But that, I think, answers your question about our average rate increase and about our financial performance. Is that what you asked?
To be frank, I'm much more concerned about the outside forces that are out of our control. And it seems like what you guys are working on, I don't discredit it, but the things that are outside of our control
they are.
is what's driving small hospitals out of business.
So you talked about UVM, right? And we talked earlier about the right care in the right place at the right time. UVM, what they do is really complex, and I meet with Dr. Epen on a quarterly basis, and I know that his focus is how do we get low acuity stuff out of the medical center? How do we get that back to the community hospitals? Now, it's one thing for the CEO to have a strategy, it's another thing to affect referral patterns, right? So the change happens slowly over time, but when they make strategic decisions about they're going to move this service from the medical center to Central Vermont or to Porter, or try to make referrals back to us, we sit on the phone with them every month and review transfers that didn't happen. They try to transfer patients back to us. We say no sometimes to patients that are inappropriate, but we also say, hey, we have an ICU, so if we can get someone out of your higher level of care to our higher level of care, right? We're unlike most hospitals. There's 3 types of hospitals in the state of Vermont. There's critical access hospitals. There's about 4 or 5 what Vermont would say are medium-sized hospitals, in the grand scheme of things are still small, and there's a university. And so those medium-sized hospitals have ICUs. We can take higher acuity patients. We can keep pediatrics or other hospital shifts. So we're working with those other hospitals to say, instead of sending to UVM, consider sending to us, which means their beds aren't clogged up with patients they probably don't want and don't need, and our beds get full of the patients, the kind of patients that we can take care of. You also heard earlier about a really complex mechanism about how our field is financed. You heard about Medicaid rates. Now, 60 plus or minus 3 or 4 points % of everything we do is Medicare and Medicaid. And if those rates are unusually low, we're nonprofit, right? So we balance that on the commercial side. The problem with that is, and in Mr. Hammer's report, Dr. Hammer's report, Vermont, New Hampshire, and Maine, you know what we all have in common? We're the grayest states in the nation. We're 3 of the top 5. So we're getting older. Our population is going in the wrong direction, right? When we talk about our partnerships, a couple of months ago, we had our incorporators meeting, and we invited the executive director of the Vermont Futures Project, who talked about just raw demand and what the need is to grow the population. We need to create all these things around housing. The reason we're involved, my staff have a hard time finding a place to live. Young people are increasingly leaving Vermont. Well, guess what? In addition to we need those people for jobs, those are also more and more people that are healthy and pay into insurance premiums that don't use healthcare that help bring those premium rates down. I mean, insurance is just a game of volume. The more people that you have in the same pool, you leverage your rates down. So it's complex. I'm trying to oversimplify it, and I'm sorry, but all those external pressures are real. But I don't want you to sit here and think UVM or any other organization is trying to drive us out of business. I personally don't believe that. Had you asked me maybe 5 or 6 years ago, I might have a different opinion. But Dr. Epen, Dr. Leffler, we meet with them on a regular basis. We have strong partnerships. I believe, and proof will be in the pudding, but I have trust and I believe that where they want to go and where we want to go and where the state wants to go is all rowing in the same direction. Now, even if we're rowing in the same direction today, it's going to take a couple of years for that to kind of manifest itself. So in a couple of years, come back and, if it works, you can say I was right. If it doesn't, you say, well, you're an idiot.
Well, that's really good to hear, because the nice thing about Burlington is it's close to Vermont.
Correct.
Yeah. Thank you. Yeah, and I just point out that, as you said, there are ways to do this, and taking care to more primary care, taking it home if that's appropriate, those are all less expensive places to do it. Now, of course, some of that you offlay on the family, right? And you need home health nursing to come help as well. But that's less expensive than being in anybody's hospital. Thank you for the question. And Peter, thank you. Other questions or comments?
Hi, my name is Jane Pusher. I am a very relatively new Vermonter. I moved here just a little over a year ago. And just about a year ago, I started working at NMC per diem. I work in your ER. I also manage your switchboard. And I can testify that we are seeing all of what we've been talking about today. I am shocked. I came from Wilmington, Delaware. We've got our choice of several huge hospitals, well, 95 corridor. We've got urgent cares every couple of miles. I was stunned at who comes into the emergency room for things that what are you doing? Like, I would never say that, obviously, but people who don't need to be there. I see it all the time. We've got people boarding there. We've got folks who are living in the hospital because there's nowhere else to go. But what I'm leading to is, I love all these changes you're talking about. I think it's going to take a lot of community education to get people to change their mindset that I don't go to the ER because I have a sore throat. I don't go to the ER because I think I have poison ivy. We've got more than a few regulars in the ER. We know we're going to see them several times a week. We have whole families who come in because maybe they have, I don't know if they don't have primary care providers, but I don't think this is an outing for them. They come to our ER and, oh Lord, they're here again. And we treat them perfectly, as we should every single time, but it's going to take a lot of community education for people to understand you need urgent cares here. I'm blown away how we don't have them, and the urgent cares are often understaffed. They close early. I'm taking those calls. Why can't I get in? Well, because they had to close early today. It's a shame. It's a wonderful community. I love being here. I also work for NCSS, so I see that side of it too. You need to educate your community as to what is appropriate, and then the access just somehow. I don't have the answers. I'm sorry. That's why I wanted to be here, but I don't know. I've run out of what else to say. But
More urgent care will be coming.
yeah, good, because a lot of times it's closed, and then they end up bringing people. We do have people who come to urgent care who belong in the emergency room. We have people in the emergency room who don't even belong in the hospital at all. We see it every single time I'm there. So
Part of what we pushed back to the state is, thank you. Part of what we've asked the state to step up and kind of help solve the problem is the skin in the game. You can go to the emergency department because there's no negative consequence for not going to your primary care, for not going to urgent care, for just walk into the ED, right? We're there 24/7, right? So, Kathy's back there, and Kathy and I talk all the time. Kathy, what can we do to help? Well, I don't know what we can do, because sometimes patients will have a 3 o'clock appointment with their primary care provider and be able to get into our urgent care at 10, and so they just not show up to primary care and go to urgent care. Well, that's a bad use of healthcare resources, right? So part of what we need to do is, and again, this is going to be painful, this is going to be uncomfortable. There was a great book written by a writer from the Associated Press who had a shoulder issue and went around to the 7 major healthcare systems around the world, and went to one of the healthcare systems, and it says, well, you're this many years old, your return on investment, I hate to say it that way, it was not in America, but your return on investment is going to be low, so we're going to put you in line, right? You go to another place, and they say, listen, the difference between rehab and surgery is minimal, so we're going to put you in rehab. We're not going to allow you, we're not going to pay for surgery. Come to the United States, we'll put you in the OR on Monday, right? So there has to be skin in the game. There has to be I hate to say it this way, but consequences. If you choose the wrong setting because you're impatient or you're not doing things right, then there should be something for that. Part of what we need to do is, if we decide to move forward with this AHEAD model, it's great. Everybody in Vermont will be in. And if you don't like it, you can drive 30 minutes across the border and go to New York, where they will be happy to charge your card. And at the moment, we don't have an answer for that. At the moment, when someone comes into the emergency department with a sore throat, we're not allowed by federal law to say, go to your primary care provider, right? We have to take them in. We have to provide what's called a medical screening, get 3/4 of the way down the road, and it's just, it's already taken the resources. So we have to figure out how we can overcome that. And part of that will be how we work with the state, and part of that will be how the providers in the state work with the federal government to design something that has value, but that also puts some walls around it a little bit. And I don't know what that looks like, and I don't think anybody does at the moment, but what I do know is that we're all committed to having the conversations.
To the algorithm, the sport, the hospital here on the road, want to keep us alive. I go over the return on investment. When I talk to my doctor, I say, there's no value in doing what you're recommending.
Yeah.
You're unusual.
So this is a big, I'm going to dip my toe in a huge issue, and then I'm going to turn around and run away. Okay, I'm just telling you that right now. When I did my studies, one of the things we studied, and the metaphor is, think about eagles, turtles, and rabbits. And eagles, turtles, and rabbits are disease. And our job is, in healthcare, is a fence. So if you're 70 years old and diagnosed with prostate cancer, I'm also probably going to say this a little bit wrong and get myself in trouble, and Dr. Menedeo is going to be like, what did you do? I got cancer. The big casino. I need to get treatment. Wrong. prostate cancer usually takes about 20 years to kill you. The chances are you're going to die from about 17 other things before prostate cancer. It's a turtle. Don't put a fence around a turtle. It's not going anywhere. If you have some other type of cancer, something stage 4 metastatic breast cancer that's just awful, we often call that an eagle. Like it's hard to put a fence around, right? It's hard to contain that disease. Again, that's definitely the wrong example, but there are diseases where no matter what we do, the outcome, we're going to have about that much impact on the outcome. So the question is quality versus quantity of life. The things we want to focus on are the rabbits, right? Those diseases where intervention provides value, right? And we have to think about quality of life versus quantity of life, right? And trust me, I speak from a position of education. I have watched time after time after time people, and even my own mother, like throw the kitchen sink at me. I don't care what you have to do. You have to get the Blue Angels here, fly the Blue Angels, but how much does it cost the rest of society? And what's the return? I hate to say it this way, but I can't really think of a better metaphor, so I apologize. What's the return on investment? Are we providing value, or are we just keeping somebody alive for a little bit longer?
And then the young people have to pay for it. And that's my biggest worry.
Right. So,
I had a good life.
again, dipping my toe in the water probably opened up a bunch of boxes that everybody's cringing at, and now I'm going to run away. But I hope you take the core message away of we have to look at what are the things that we can actually provide an intervention that will make a meaningful difference, versus the things, no matter what we do, it's not going to make a difference, or you don't need to treat this because it's not going to harm you.
Thank you.
Yeah, my father taught me that almost every man dies with prostate cancer. Very few die of prostate cancer, but that's part of the prognosis and the discussion, right? So we are at 8 o'clock. You all have been extraordinarily patient, very perceptive in your questions, and very helpful with your comments. So we've learned a lot. We can take this back now as we think about some other things that might be done to get our report together. I'm going to be here for a few minutes if you want to come up and talk. Please remember that you also can make comments on the website of the Green Mountain Care Board. And we will look at those and take those into account as well. So thank you very much. Hope the rain has stopped or will shortly, so you'll be dry when you get home.